was just telling my friend Jim Roush that today we'll be discussing Bayesian comparative effectiveness, which is a non-parametric technique for comparing treatments to one another that have not been previously compared as different arms in a prospective clinical trial. Please ask any questions during the presentation. This technique has great potential for research planning. Finding out what work needs to be done is worth pursuing.
Okay, so objectives for today are introduce a data synthesis method useful for planning research. So if we want to plan research, it'd be nice to know where the best potentials are for uncovering human knowledge. Demonstrate the analysis and how to interpret these results. As we know, there's a lot of studies coming at us every day. I subscribe to browsing to some like 2 or 3 journals, and I'm getting 4,000 new entries a month or something. It's just it's hard to handle all the data that we're getting. So this is a way to synthesize those data. I worked in smoking cessation for 4 years at the University of Arizona. Go Wildcats! Anyway, and it's a very interesting area. Arizona is actually a pioneer in smoking cessation. They were the first state to pass an anti-smoking law in 1972, I believe it was. So they've been on way ahead of most states in that area. The question that came from a boss of mine was, we know we have even Cochrane collaboration evidence syntheses that show different cessation methods as compared to control groups. So we know physician advice, for example, against control groups. We know Quitlines against control groups. And we know social support against control groups. But which one works the best? Well, if you look at Cochrane collaboration, unless they've changed that in the last few years, they tell you more research is needed and this and that, and you don't get any clear idea of which treatment is the best to use because they're not compared. The first step on this particular project was to come up with a definition of quitting, and that means not smoking 1 cigarette for 365 days. And that's a pretty strenuous quitting definition, but at least that's what we were using. And most of the data is, published studies are based on that definition. We can throw in a salivary test for cotinine to compare to see if there's nicotine being consumed and thereby see how much of the truth is present there. So here's some pages out of Cochrane collaboration. These are all studies down the left-hand side with their dates and then their results as effect sizes, risk ratios in this case. So, and then the summary at the bottom with the overall or average effect as to whether the treatment was effective overall or not. And you can see some studies show it was effective. The ones on the right are the effective ones, and a couple of them are spread out over into the control group was more effective. I'm just going over that in case it's been a while since you've seen these. Telephone Quitline, as I said in my presentation, my quick presentation, that there's some big companies now that are doing this and our states are subscribing to them. So they're up in Seattle, and there are people, for example, up there that will take your call and help talk you through quitting. And we found, we had a Quitline down there at Tucson, and we found that just after New Year's, there would be a peak time for quitting. New Year's resolutions were kicking in. And then the physician advice. How important is it for a physician or other trained healthcare professional to say, it's time to quit? Is that more credible than social support or Quitline, or more powerful, more effective? So as an example, we had smoking cessation studies. These are just made up data, but I might have one trial where we have a control group A, and what would be, of course, the spontaneous quitting of cigarettes without any intervention versus physician or social support. There might be 12 trials that have just no contact versus physician support. So we have a lot more data there than we do on the first one, and so on. So I realized that I don't have a lot of math here for you. So in fact, I don't have any. So that I'm kind of pleased with myself. This is all conceptual, and we'll get into computer code in a minute, which isn't so friendly. But the idea is that you have a control group and you compare to social support. That's one study, let's say. So in that study, you have some variability in the control group, and you have that the social group shifts the data somewhat, makes the quitting more probable. And that's all science is, really, in that one definition. And so as we add other studies, the controls might fatten up a little bit. There might be more variability in the controls. But if you think about it, you still want the treatment to be better than the control group in terms of its mean quit rate. And then finally, throw in, this is all made up, this is just for conceptual understanding, that the physician intensive and the physician minimal, and I'll just define what those are. Minimal is, Jim, you've been smoking for 30 years, your blood pressure is high, you're rusty between years, it's time to quit. Versus the intensive, which is quit or you're going to die. I'll give you 6 months to quit. And we could scare the heck out of people, get them to quit, physician minimal, time to quit. We find that one of these points of quitting is when a smoking mother is pregnant. She will quit for the baby, for the welfare of the baby. Men are not so easily influenced. Comparative effectiveness, meta-analysis, this is another idea, get a made-up idea where we might say, for back pain, for chronic back pain, which is the best treatment? This is a big deal. I mean, everybody's an expert at back pain, which makes me think nobody's an expert at back pain. So, but I digress. But let's say if I wanted to compare spinal manipulation to athletic training, that would be the route going through shared control variants or shared control outcomes. I might want to compare medical management to spinal manipulation. I could go that route. Just giving you the concept of this. If I want to compare self-care to spinal manipulation, I could do that, for example. That's oversimplification in a way, but what we're doing here is going off that nucleus of control groups. Yes, Dr. Bay, what is your question? The control group, does it have to be the same in every instance? Now, this is a great question. I'm glad you asked it. Control groups are going to be heterogeneous, aren't they? If we could use the 50-cent word for this, they're going to differ. Some controls are placebo. Some are going to be waiting list control. Some are going to be, diary where they're not even coming in for care. So there's going to be a lot of variability in the control group. So as that variability expands in the control group, that could knock down our net treatment effect. So one way to handle that is to create several control groups as if they're different treatments. Okay. All right, so this is the program. Does that answer your question, sir? Do they all have the same effect size? The control groups act as treatments. They're just another form of treatment. And so when you think about it, people get better under control groups. We just hope that our treatment gets them better, right? So more better. Okay, so this, and I'm not really, not an expert on Bayesian meta-analysis. This is one technique that I've learned that I really like. I think it has wide applicability. And I'm using a software program called WinBugs. It's made in England, and like all things made in England, you have to tinker with them to make them work. If you buy a 63 Triumph, you fix the brakes and the headlights fall out, and you work on the engine and the trunk doesn't work anymore. And I don't know, it's probably unfair. Okay, I'm sorry. I'm going to get this ready. This kind of give you an appreciation for how finicky this is. I use a lot of color and notation to make it applicable to different problems. So if I bring in a new data set, this cues me as to what parameters need to be changed in the model. So I don't have to rewrite the code from scratch every time. And what this does is, here's some of the data. There are 47 studies here. And the study numbers go along the left-hand column. The treatment type is the second column. The ones who responded to treatment are under this R, and the total number of patients in that study, in that treatment arm, are on the fourth column, and B is the comparison. So you break each treatment arm out of a study and you give it its own line of description like this. And the B1 means it's going back and comparing to the placebo group for that particular treatment arm. So out of 47 studies, I've got, well, just 47 lines of code. Is that right? No, because the study number may have 3 treatment arms. So I was hoping I could just tell you how many lines of code there or lines are there to describe the studies. Any questions or comments? Yes, Lise?
Is this a model that you created and it's new, or is this something that someone else's theory that you're applying your data to?
This is a theory that I'm applying. Yeah. It's called the random effects model for Cochrane data. It works best for binary outcome data. Quit smoking or not quit smoking. It keeps track of the study number and it looks at the random effects attributable to that study. What we're talking about here is that each study is different, and you're going to have a different population or different sample that you're working with. You're going to have different outcomes. So this is it's adjusting that out, that there are going to be different results from different studies. Just a second here. I'm loading the data. Interesting thing here with the data load is that we can have a sixth column, which is the quality of the study. So we can keep that in mind. Some studies are better than others, and some people have rated those. At Cochrane Collaboration, you might see that they said this study is a good study, its quality is high, it has a control group, it has random assignment, things like that. And this is a bad one because it doesn't have randomization. Now, one of the things about a Bayesian analysis is that it assumes, or we can assume, that we already know something about what we're researching. And this makes a lot of sense, but we don't do it. So if we have tons of studies on physical therapy and low back pain, I know some of those, why do we start over every time with a control group, assuming there is no effect in the control group? We'll be surprised if we find out that the treatment works. That's essentially what we're doing with hypothesis testing. We're shocked every time we find a p less than 0.05. But what we should be doing, and it makes more sense, if I may, we should be building on our science and saying, now we know in the past 30 years that this is good for low back pain. So now we're going to add this little piece and see if that makes it better or worse. All right, so this is the fun part. Hold on, you're waiting for the fun part, I know. Okay, so what this is going to do is it's going to sample 50,000 times from all these different treatments versus the combined control group. And for those of us that like Star Trek, this is just as good as it gets. So what it's doing is it's going to sample 50,000 times, and every 100 samples, it's going to show us what's going on there. And you can see it's counting up over here. It's up to 25,000 almost. Now, Where I don't trust this is sometimes the effects are very small. The differences are very small. And when we're doing sampling like this, bootstrapping or sampling, you're going to see the differences look bigger because your variance is decreasing with all this fancy stuff we're doing to it. So what we're doing here is what we're using is the prior is 0. In other words, we don't think our treatment's going to work. And we've never investigated this before. So we set what's called an uninformative prior, 0 effect size, and then run it. If we had some prior knowledge, and most of us should in our research, we would set that as our prior. Okay, here are the results. And we can look at statistics. There's the statistics coming up. More important for us is this. The number 1 condition, listed as number 1, is the baseline condition. So this would be a control group where there is no intervention. And we could define what that is if we need to. But what we're seeing here is I forced it to rank the treatments. So the higher numbers are worse treatments. And we have 5 different treatments. And the first one is the control group. So I'd like to see the preponderance of evidence toward the high end here, which means it's not a good treatment. So the control group is somewhat effective, but the first thing I want to look for is that it's that way. If the control group is very effective, let's treat people with a control group, right? And then the Quitline, number 2, is here. And its average, if you get the hang of reading this thing, the average is around 3 to 4, somewhere in there. So it's better than nothing. And then group number 3 is physician minimal, where I only threaten Jim a little bit. I'm being nice, and yeah, if you quit, it'd be better for your health. And if you got something to live for, you know, think about it. Physician intensive, and you can see the mass, the probability density function, or the mass, is moving to the left. So the physician intensive is more effective. Scare the out of your patients is more effective than being nice to them. And I can give you the statistics by hitting that button as to the median. We look at the median here. For physician intensive is quite a bit better. And then social support. Any comments about social support? Some work, some don't. It's a split. So we might want to go back in and see how these guys differ from this guy, or that series, that series. So that's the demo. This is real data.
From data sets that you had or interpreted data sets?
I went to the Cochrane collaboration and got their secondary data. I didn't have their raw data. I had their summary data, which is what I needed for this. How many in a treatment group and how many responded. Now, this is what I did for chronic low back pain, where I had 8 different therapies. I could show you this another time, but the same idea. You could get the difference between DCs, MDs, DOs, and physical therapists for manipulation, which is interesting. All right, Bayes' ways, making a little rhyme there, but we're actually testing hypotheses. We're trying to match data to hypotheses. And which hypothesis best explains the data is the way Bayes works. Whereas frequentist methods are just testing the data to see if they match a single hypothesis, the null hypothesis. Anyway, comparative effectiveness across different studies. The exciting part about this is that it can reduce the need for prospective research. If I had to answer that question about which smoking cessation was more effective, well, I'd write a proposal to NIH. With Gene's help, I'd get $10 million. And we go out and randomize these people to these different groups. It'd be a pain in the neck. A prospective research with 5 arms, and as to which one is more effective. Now, that doesn't mean we shouldn't do that someday, But when comparative effectiveness was introduced under the Accountable Care Act, I see this as a way to kind of narrow down what we should test prospectively. Social support was intriguing. We might want to just focus on that against physician-intensive advice. As to whether we are ruling out weak treatments or ruling in strong ones, I don't know. That's an area that we should research. So with thousands of studies, we might be seeing that one is just kind of a dud, not better than control. Or we might see one that starts to stand out. And that's the conservative versus liberal notion. Are we going to miss something that's really important, or are we going to say something's important when it's not? And another example is our alternative medicines, which I don't need to get into. So this is another tool for better decision-making, a guide for research investment. And it's something, again, that a small medical school and its many programs could undertake. This is a picture of a network meta-analysis, which is the fancy name for it. So warfarin has been compared to aspirin in 7 studies, and adjusted low-dose warfarin to placebo with 2 studies. And this is kind of what I could have mapped my data on. This is the new way to do that. And then the size of these dots can represent effect sizes, relative effect sizes, I guess. So, but I haven't done it that way. Okay, so I-squared, we won't talk about likelihood, but does high variability mean poor quality? You know, if we're doing a study and our control group has a lot of variability in it, and our treatment has a lot of variability in it, is that sloppy science, or is that just the way people are responding to the care? And I finish with Gauss. Okay, so I'd like to convert this now to a discussion and not a lecture.